and welcome to the Helen Bader Foundation CBRF Caregiver Training Program. This unit is on the assessment, ISP, and annual evaluation in the CBRF. As a caregiver, it's important for you to know how to determine a resident's interests, needs, and abilities, and how your CBRF might best be able to serve those residents. I'm Maren Meyer. I'm a pharmacist, and I'll be presenting this unit. My interests are in long-term care of all kinds and also in public health education. I've been providing a program on medication safety in the CBRF since 1994. And I've written a couple of books that are related to the topic. One is a guide for pharmacists, which is available through the Wisconsin Pharmacist. And one is called Coping with Medications, which is for elderly individuals and their caregivers. Now, at the end of this unit, we have a mock interview, and the participants in that interview are Jan Lathrop, who is from Instructional Development, and Phyllis Woeful, who very kindly agreed also to give her time for the assessment. Each of our units in this program begin with a pretest. The pretest and post-test content is identical, and there's no grading on these tests. The tests are designed to give you an idea of what kind of information we want you to learn, what kinds of things you already know, and they really aren't intended to cover all of the information. They're just to give you a general idea. So what I'd like for you to do now is to stop the video, take the pretest, and then come back. Welcome back. Now, throughout the program, feel free to stop the video anytime, repeat information if you need to, stop and come back if you're losing concentration, and take notes anywhere in the workbook that you want to. It's just for your use. Let's start with an overview of this unit. This unit is going to cover information about the resident's record in general, the assessment, that's the pre-assessment, the individual service plan, the annual evaluation, the care of respite and terminally ill residents, some interviewing skills and techniques, and then the demonstration of an assessment interview. At the end of your workbook, you'll find relevant parts of HFS 83 that pertain to the information presented in this unit. Let's talk about the resident record. The CBRF has to keep a record of each resident, and there are certain specific bits of information that need to be kept there. This can be a very useful tool for you as a CBRF caregiver. And even if you're not the individual who performs the assessment, you probably will be performing a daily monitoring of your resident to see how they're doing, to see if their needs are being met. And so you'll want to know this information. So some of the information that is required, all of the information is listed in your workbook, and I'm just going to go through some of it. First of all, you need to have an admission agreement. The admission agreement has to be completed before admission to the CBRF. You need to have identifying information about your resident. That would include the resident's full name, social security number, sex, date of birth, last known address, and where their next of kin can be contacted. That would also include their designated representative or power of attorney. You need to have in your records their medical history, social history, psychiatric history if any exists, who their current personal physician is, and copies of any changes or resolutions that affect the resident. That would include things like transfers or discharges, transfers say to a hospital, nursing home, and then back to your facility. What kind of services are available at your facility? What kind of services have been agreed upon and the fees for those services? What the physical and mental condition of the resident is, information about any situations that may have occurred involving abuse or misappropriation of property, information about the death of the resident, and incident reports that you may generate as the resident continues to live with you. You also want to have the initial and subsequent health assessments of your resident. You want an evaluation for the purposes of evacuation, should an evacuation ever be necessary, and significant illness or incident reports. This unit is going to focus on the assessment report, the individualized service plan, and the annual or semi-annual evaluations. But your records will also include any reviews, discharge papers, HFS approved use of physical restraints, a summary of grievances that might be filed by the resident against the facility, copies of the plan of care for terminally ill patients, a description of behaviors that might be harmful either to the resident or to others within the facility, and a copy of all physicians' orders. In addition to that, I would also keep a copy of the medication administration records. Now, in B, we see who has access to the resident's records. It's very important that you know this information. The resident, the resident's guardian or agent, or designated representative who is authorized in writing by the resident can inspect or copy or challenge the accuracy of a resident's records. No one else, okay? Only employees who are directly involved with providing care to the resident or authorized representatives of the State Department of HFS or a third-party payer are also allowed access to those records, but only the records that are pertinent to them. There is also the exception of a licensed hospice or home health agency. So those records are really very personal and confidential, and it's important that your residents realize that their health care information and their personal information is just not privy to everyone. Some important things for you to remember is that this is a right of residents to have this information confidential. And if you need to discuss a resident's case, it should be done in private, not out in the hallway where other individuals who are not involved in the care could hear it. You don't want to discuss a resident or the resident's care with anyone who does not need to know and is not one of the authorized individuals. And remember that when you're treating your residents, you treat them with the same respect and dignity that you would expect yourself. Let's move on to the assessment. The assessment is basically a written report that's obtained as the result of a face-to-face interview with your resident, the resident's caregiver or guardian or family members. The initial assessment benefits all the parties that are involved, and what it does is it assists both the prospective resident and the CBRF in determining if your CBRF is an appropriate environment for that resident. It allows you to collect all the information that you need to use for the individualized service plan, and it helps your staff get to know the resident and determine what their interests are at the current time, what their abilities are, what kind of support systems they need. So who does the ISP or the initial assessment? That can be anyone who's authorized and trained to do it. In this case, you'll see that I do the assessment, and I'm a pharmacist. I'm not a nurse, just sort of a regular person, and I've taken an interest in interviewing. So the staff person designated can be an administrator, a manager, a nurse, or another staff person, in this case, me. What does HFS say about the assessment? It needs to be completed before admission on almost all CBRF residents. And if there's an emergency admission that's been initiated by the county, it has to be completed within 5 days of admission. It is a written report based on that face-to-face contact, and it becomes a permanent part of the resident's record. It's based on all the current diagnostic, medical, social information that's obtained from all possible sources. That would include the current healthcare providers, any case managers, through insurance companies or through the county, or say licensed therapists, audiologists, just anybody who might be providing care in any way to your resident, including the family members. So this interview is held with the designated CBRF member and the prospective resident and hopefully family members of the resident. And what it does is it lets you find out what their abilities are, what their knowledge is of your facility and of their condition in general, what their needs and wants are, and what their expectations are of living within a CBRF environment. The initial interview needs to be agreed upon. The content of that interview has to be agreed upon by the participating individuals. Now that seems so simple, but sometimes your evaluation will not be in direct accord with what the resident or the resident's family views as the status of that residence. So it needs to be agreed upon and signed at the time. And then it needs to be reviewed. It can be reviewed at any time by HFS to determine if your needs of your residents have been properly documented and if the needs are being met, and if you are the appropriate type of CBRF to be serving the resident. Before completing the assessment, the CBRF needs to obtain written authorization from the resident or guardian in order to obtain a release of information from the healthcare providers. Those healthcare providers should be the most recent and knowledgeable ones, and you need to be sure that you include the medical, social, and psychiatric history of your resident. So you obtain all the information in advance of the assessment. You need to provide evidence that family members have been invited to participate in the initial assessment. So what you would do then is simply have a letter that you send to the family members and keep a copy of that, telling when you sent it and documenting any responses that you've obtained. And you would keep that in the records section of the medical chart that you create for each resident. You want to formulate an assessment that reflects the interests, abilities, needs, and wants of your resident. So what does an assessment include? It's a very thorough instrument. It includes the physical health of your resident, and it involves identifying any chronic or short-term illnesses, any recurring illnesses, physical disabilities or challenges, restorative or rehabilitative care that they're receiving or need to receive, and any significant changes. And those significant changes will have to be documented on the specified mandatory HFS significant changes form. After the physical health is covered, you need to have an assessment of the medications, and that includes what medications the resident is currently taking and the resident's ability to manage or administer their own medications and whether they're doing that now or not. Now, in the medication unit, there is a med-assess which will help you in determining whether or not the resident has this knowledge, skills, and ability to do that particular task. You want to identify what the CBRF's responsibilities would be related to medication management and administration. Then you want to look at what kind of nursing procedures are going to be needed by this particular resident. How many hours per week will be required to meet the resident's needs? What is the resident's mental and emotional health? What's their self-concept, their self-esteem, motivation, their attitude towards others and themselves? Do they have symptoms, active symptoms of mental illness? And how willingly do they participate in their treatment and therapies? What are their behavioral patterns? Do they have behavioral patterns that are harmful to other people? Or are there measures that can be taken to supervise the individual and help them better cope with their environment or control any harmful behaviors that things that might be harmful either to them or to other people. Do they have the capacity for self-health care? And this includes actually all of their activities of daily living. What kind of personal care services do they need? Do they need help with grooming or hygiene? What kind of adaptive equipment is needed, and do you have it or do they already have it? What's their capacity for self-direction? Are they able to make their decisions and needs known? Are they able to act independently? And how do they verbalize those things? Socially, you want to know if they're interested in participating in group activities. What kind of interpersonal relationships are they most comfortable with? What kind of leisure activities do they engage in? And what community and family contacts do they have that you'll want to help them either sustain or improve or work with? Do they have vocational needs that need to be met? Other requirements for the assessment include, before a resident is admitted to a CBRF, you need to determine who is going to be communicated with regarding the resident's health, safety, welfare, and rights, and how specifically that will be done. Before providing any services or care to a new resident, either the supervisor or the administrator or a designated person from the CBRF needs to establish exactly what services and care and supervision are going to be provided. That needs to be very specifically designated. And that individual or other specified individuals will be reviewing the resident's assessment and their individual service plan before providing that care. You can't just sort of blindly walk in and hope that you know the needs and wants of a particular individual. You need to have continuous access to that information because, of course, it's a very lengthy document and you can't learn it all at once. It tells everything but the shoe size of an individual, essentially. You need to have information about an individual resident's behavior patterns before you begin interacting with them, because you may create a situation that could be harmful either to you or to the resident or others. So within 30 days of admission, you need to obtain written authorization for access to the resident's records and any other action for which prior authorization would be needed, for example, for restraints. But ideally, you want all of that information prior to admission so that you really know that you have an appropriate admission when you have a new resident coming in. I want to go over one of the suggested assessment forms. This was a form that was developed here at Waukesha County Technical College by Wendy Simon. And while it's not a mandatory form, it is a good form. I've been through it, and I think it covers all the information for you. You can do this assessment in any order, but we'll cover it in the order in which it's presented in your workbook. First of all, remember that you, when you do the assessment, are going to be looking at the ABCs. That's the appearance, the behavior, and the communication patterns of a resident. So you're not just gathering written information. You are, in your face-to-face communication, you're gathering other information, visual, audiological information, what are the smells and sounds and sights related to that resident. And also remember that if there's a hint, even a hint of dementia in a prospective resident, you want to make sure that there is a power of attorney in place for the resident, just for their own protection and to assist you as a CBRF caregiver. So on the first page, you'll see that we have the general identification information. First of all, it tells who's collecting the information and who all was involved and when it was done. It seems so simple, but a lot of times that kind of thing gets forgotten. It tells everybody who was present at the initial assessment. Then it has identification information, including the resident's name, marital status, sex, address, phone number, and prior living arrangements. It has their admission vitals, their vital signs being blood pressure and pulse, their last physician's appointment. And in my case, I wouldn't be collecting that information. I would be taking it from the healthcare information that I had gotten by a release signed by the resident or the prospective resident. So that's information that I would take from the records and put here. Now, the nurse that assists me at my CBRF might update this information too. But it's very important to have, for example, the date of the last tuberculosis test. You want to know who their primary physician is, how to contact that individual, what kind of practice they're in, who their hospital preference is, and what their code status is. And remember that when you work with code status is not something that just happens once. Code status is something that can change at any time. People have a right to change their minds. While somebody might not want to be resuscitated today, they might change their mind and tomorrow say, well, yes, I want all measures taken. So that's not just a stationary, static thing. It's something that's dynamic and subject to change. And that's good that people think about it. On page 2, you'll see that we have the primary contacts. And you'll want to know not just the primary contact, but who the backup person is when your primary person has gone on vacation or has an illness of their own. Are there any guardianships? Are these legal guardianships? And you want to have the paperwork that goes with those. If the individual has insurance, you'll want that insurance information, and probably you'll end up inserting a sheet in your records with a copy of that information. Then at the bottom of page 2, we start with the medical information. You'll have the diagnosis, whether it's chronic or short-term, current, or a past condition. For example, in the past, the individual had a fractured wrist. When did that occur? You'll want to have a date there so that you'll know if these are current or past conditions. Page 3 gives current medications, the dosages and times, and also the reasons for taking those medications. There should be no medication listed here that doesn't have a purpose or a reason that is explained under the diagnosis section. So if you have a medication and there is no matching diagnosis, it's something that you would want to check with the physician or primary provider on. Be sure when you look at the medication section that you fill in the allergy section. Knowing an individual's allergies is extremely important. As a matter of fact, you may want to put that in red on the front of their chart. At the bottom, you have, bottom of page 3, it talks about medication administration and management. And remember that the CBRF environment is one in which we want residents to be as independent as they can safely be. So try not to commandeer this responsibility. It seems easier in many cases for you to just do it for someone. But people's self-esteem very often relies on having control over parts of their own activities. And this is one where you can help people gain independence rather than lose it. So at the very bottom of page 3, there's information about the resident's pharmacy, who their preferred pharmacy is. And remember that you cannot force an individual to use a particular pharmacy. On page 4, you'll see we go into sensory status. How is their vision, their hearing, and their speech? And it's fairly straightforward. You want to know if they've had cataract surgery, if they have lens implants, do they use glasses, or how old are the glasses? Are they able to read with them, and with what visual acuity are they able to read? You want to know how good their hearing is, and if they use a hearing aid or hearing aids, and do the hearing aids work? Do they know how to operate them? And have they had, for example, problems with earwax, which, as you recall, is one of the predominant causes of hearing loss in elderly people? Under speech, you want to know what their primary language is and what their preferred language is. Can they speak well? Is there a communication deficiency that will make it difficult for you to understand them, even though they can express themselves well. So you'll need to not just complete this from their medical information, but also check with the resident, because this is a very subjective area here. People change the extent to which they use these assistive devices. On page 5, there's a section called mental and emotional status. It would be very difficult to say to somebody, are you confused, anxious, forgetful, and depressed? I don't think that would probably be very appropriate. So this is information that you are going to collect by talking face-to-face with both the resident and the resident's family. And at some point, you may need to say, are you fearful about coming here? Are you fearful about the nighttime? Or are there sounds that frighten you? Okay? You may need to come straight out with some of those questions, but you do need to use some degree of sensitivity in posing questions to get the answers to these particular issues. But you do need to ask about people's self-concept and attitudes. And here, be sure not to use leading questions. Ask questions that are easy to answer honestly. And so those are questions that are not judgmental. You want to know if the individual enjoys interacting with other people or if they're shy. Do they normally feel comfortable with themselves, or do they just see themselves as being someone of not great importance or worth? It's important for you to know that information because you want to create as helpful an environment for a resident as you possibly can in your facility. What harmful behaviors are there? This is probably going to be documented in the individual's medical and psychiatric and social histories that you obtain from providers. But the families may also provide some of this information. Residents may have less of a tendency to be forthcoming with that information about themselves. However, one thing that I have found with working with elderly people is there is not a problem with coming straight out and saying, do you ever have suicidal thoughts? You would be surprised how many people do say yes, and it's something important to know about. On page 6, by the way, you're putting the resident's name, full name, and medical record number on the top of each one of these pages, I hope. Okay? On page 6, we're talking about the capability for self-care or acting independently. Can the individual respond to verbal cues? Do they need guidance in following directions? Do you need to segment tasks to make it easier for them to work with a particular task? What kind of prompting or guidance is needed in particular situations? And what you may find is you're going to have more information than will even fit on this form, at which point you just put a note here that says refer to, and then whatever section of the chart you've written the information in. And be sure you date that information. Then we move on to self-care, and it just goes through blow by blow each of the activities that a resident needs to be able to perform, or somebody needs to be able to perform for a resident to exist in their daily life. So it starts with bathing. Does the resident need assistance with bathing? Do they use a tub or a shower? Maybe they need assistance with shampoo. A lot of individuals, as we talked about in the medication section, have difficulty lifting their arms above their head. Sometimes individuals will need a tub chair or a bath chair or even a lift, and you need to know that before they're admitted. What kind of skin care do they need? Is there special skin care because they have diabetes or some other condition? Do they have edema? That would make their skin more sensitive. If it's an older individual, they may have skin that's very prone to tears. So you need to know what kind of products they're using for that. What kind of oral care do they receive? A lot of individuals who have had disabilities have received very poor oral care, and this is a very important section. People cannot maintain their health without good oral care. So you need to know, do they have dentures? Do the dentures fit? If an individual's lost a lot of weight, remember that their dentures are probably not going to fit well. So, do they have their natural teeth? Who's their dentist? And when did they last see that person? What kind of grooming do they normally undertake? And do they need any assistance with it? Everyone likes to look nice. Looking nice makes it easier for people who don't know you to treat you well. Maybe that is not the way life should be, but it's the way life is. It's easier to approach someone who is well groomed. So we want to make sure that our residents get their fingernails and toenails clipped and their hair cut and permed, and offer them the assistance that they need there. A lot of people will need some kind of assistance in dressing. What parts of dressing does an individual need assistance with? Is it somebody who can use Velcro closures and be totally independent? If that's the case, you might want to help them steer towards that direction. Do they have splints or TEDs or something that's kind of difficult to maneuver that you would need to help them with? All of these things all these services that you would be providing are going to take you time. So you're going to need to know how much time is required just for the daily activities to determine if your facility can actually provide the care that the CBRF resident is going to need. Does the individual ambulate alone? Do they need any assistance? And how prone are they to fall? For example, do they have a condition like Parkinson's or dementia that would make them predisposed to falls? Do they use a walker or a cane or a quad cane? And are they able to climb stairs? This again goes into the issue of what kind of evacuation plans would you need to have for an individual? What kind of dietary assistance is needed for this particular person? Do they feed themselves? Do they not only need encouragement but also physical assistance or some kind of assistive device? For example, a big handled spoon for someone who has rheumatoid arthritis in their hands. Do they eat a lot of food at their meals, or are they a grazer? Do they eat throughout the day? Is there some kind of difficulty that they have swallowing or chewing foods? Those are very important things to know. How often are you going to weigh this person, and how much is their weight fluctuating now? Moving on to page 8, you need to be really candid and non-judgmental when you come to substance use. A lot of people use alcohol. You need to know what alcohol consumption they have, what consumption they've had in the past, what kind of tobacco use they have, including chewing tobacco, pipe tobacco, and you need to know if that's compatible with the circumstances of your CBRF. Finally, it's important to know what kind of sleep habits an individual has developed. Do they sleep at nighttime? Maybe this is an individual who worked nights and sleeps in the day. If that's a disturbance for your facility, you need to keep that in mind. Is this person going to fit into the flow of activities in your facility, or are those activities going to interfere with the resident's sleep? Are there medications that are being used to help the resident sleep? This is important to know because of the potential for falls. Getting into elimination status, you need to know if the resident is incontinent of bowel or bladder, and whether there are circumstances that predispose the resident to having problems. For example, maybe they have a catheter, maybe they've had some kind of a surgery, or maybe they're on some kind of medication to help them with an incontinent problem. Do they use some kind of a pad or a brief? And what's the source of those? How frequently are they changed? Is there a skin condition that's associated with those? Do you need to help the individual toilet? Perhaps this is somebody who could toilet themselves but can't get up off of a toilet seat. So you just need to know exactly what the circumstances are. Now, when you're doing this assessment, you can see that this becomes very personal. You want to start with the least Probably you want to start by creating a rapport with an individual before you get into the very personal information. And you can have them complete part of this assessment before coming, and then you can go over the information together. That way it would be a little less embarrassing for the resident, although some residents wouldn't be embarrassed at all. Under page 9, where you've added the resident's name again, you have a description then. You have a pretty good idea of what kind of nursing care you're going to need, how many hours per week, and who's going to provide it. You also can get an idea of what kind of therapies are being used and what kind of assistive devices and who are providing them. Also, you would include there things like oxygen therapy or some kind of pulmonary assistant therapy. What kind of transportation is provided for your resident? Are you going to be providing that, or when the resident goes shopping or to the doctor's or dentist's office, who's going to be doing the driving there? Finally, on page 10, you have the social history. This is a fun part, and it's a nice way to actually to kind of start your assessment, because you can ask the individual what they did throughout their life, what their education background was, what kinds of duties they did, which ones did they enjoy doing. It'll tell you a lot about the individual and their attitudes towards life. What kind of spiritual practices does the resident have? Maybe they were brought up in a particular religion, but they don't practice that religion now. That's important to know. You don't want to offend or be coercive in any way with religious and spiritual practices. Then we go on to social participation. What kind of entertainment does the individual like? Maybe they play bingo. Maybe they've been going to the casinos. I know that's very popular in my area. Do they like television? What kind of television do they enjoy? Do they read? Do they need special reading materials like large print, or do they have books on tape, on audio tape? What kind of music do they like? A lot of residents who are no longer able to read or even follow television programs because of dementing disease will really enjoy and be soothed by music. So it's important to find out those kind of preferences too. The other thing is, what kind of hobbies did they enjoy, and what kind of hobbies are they engaged in now? Sometimes you can help someone who is losing a lot of their abilities because of dementia. You can help them create new hobbies that are more suitable to their current status by knowing what their hobbies were in the past, what kind of games they enjoy. Do they enjoy ironing clothes or folding clothes or doing the laundry or hanging laundry out or pushing a vacuum cleaner, whatever it may be? Do they like to walk? Do you have a place where they could engage in the physical activities that they enjoy? And what kind of community activities are they involved in? A lot of individuals maintain their memberships in the Lions Club, for example, even though they're retired and not living in their own homes. So before wrapping up the initial assessment, keep in mind that you've gone through and you've asked all of these questions, but your resident and the resident's family members are also interviewing you. Will you and your CBRF and the services that you can provide meet the needs of that particular resident? So remember that it's a two-way street, and offer the resident and the resident's family time to vent their frustrations, express their fears and concerns, and to ask you questions as well. And you might want to offer to write down answers for them. Finally, before you've completed the assessment, you need to have signatures from all of the participating important parties on page 12. And on page 12, there's also a signature area for the annual assessment. My guess is that after a whole year, the assessment will have changed enough that you may need a new form. Now, we're going to move on to the individual or individualized service plan. What is it? We call it the ISP, and it's a written document that's developed from the assessment with the cooperation of the resident and the healthcare providers and the staff members that will be involved with the resident's care. And it lays out the needs and wants and goals for care for a resident in your facility. It's essentially, it's a roadmap that's given to caregivers to allow them to navigate the waters of caring for a particular person. Who completes it? Again, this is something that is completed not by one person, but by several people, preferably in a group together, talking about what they know about the resident with the resident there, so that they can determine what that resident's actual goals are. And you need to remember that, again, it's a dynamic instrument. It's not something that's just cast in stone. It can change. And sometimes an acute illness will make your goals be put on hold. And once that illness is resolved, your goals can be resumed or rewritten. Under D, you'll see that HFS has some very specific things that it says about the ISP. First of all, it has to be a written report based on the pre-admission assessment, and it becomes part of the resident's record. It must be completed within 30 days of the resident's admission to the CBRF. The assessment is done beforehand. The ISP is something that you develop as the resident becomes more comfortable in your CBRF and as you get to know them better. This form that we've provided in your workbook is not a mandatory form, and you can use a different form, but I would suggest that you talk to your Department of Health and Family Services examiner to make sure that your form contains all of the important information. The ISP needs to be completed by the staff with the resident and the resident's guardian or agent or power of attorney and anyone else who's involved in the care, okay? It sets the goals for individual services and activities. It tells how often services will be provided, what the services are, and specifically tells who is responsible for providing the services. It needs to be agreed upon and signed by the CBRF representative, the administrator or his designee, his or her designee, the resident, and the resident's guardian or agent. It is to be reviewed every 6 months at least, or with significant changes in condition. And it may be reviewed by the department to see if the resident's needs have been properly documented. The ISP includes things that come from the assessment. So I'm not going to go through each and every one of these items. But what you'll find is that it has the same things. It addresses the physical health needs, the medication health needs, the nursing procedure issues, and how many hours a week are going to be provided and when they'll be provided and by whom, and what the goals are of providing that service. It'll address their emotional health, their behavioral patterns, any goals that you have for behaviors, and what measures are going to be taken to supervise the individual or to help them adapt to the setting. It's going to address their capacity for self-care, any personal care services that are needed, and specifically who will provide those services. It will talk about their self-direction. And finally, it sets goals for things like social interactions. The goal for an individual might be for them to participate weekly in one group event, if it's someone who is very withdrawn. It's important to set those kinds of goals because when your setting, your environmental setting changes, it's easy to become overwhelmed, particularly if you have a dementing disease. And you don't want an individual to withdraw and become less socially capable. You want them to become more socially capable if it's possible. So there are other requirements that are related to the ISP. First of all, you need, as a CBRF, to provide the program services that are identified in the ISP. Either you can provide them yourself, or you can contract for those services. But you must be able to provide the services that are outlined in the ISP. You need a written agreement if you're going to contract with other agencies to provide services. And they have to be delivered in a way that is convenient and reasonable for the resident. Finally, if you have a resident with a diagnosis of a terminal illness, you need to have a cooperative agreement with either a hospice or a home health agency to provide the coordination of care for the resident. Now, we're going to be looking at the individual service plan. We have a form here. This is just a model form. It's from the Department of Health and Family Services. And I'm not going to read every page to you, but you can see that it's very comprehensive. And it could be a very useful tool if it's both filled out correctly to begin with and used on a regular basis as a reminder of what kinds of goals you have for an individual. Now, let's review the ISP form itself. This is from the Department of Health and Family Services. On the first page, you'll see the identifying information. That includes the resident's name and the facility name, signatures of the participants. It has information about medications, nursing procedures, allergies again, not just drug allergies, but allergies in general, capacity for self-direction, advanced directives, and your resident should have these, supervision, and capacity for self-care. The next page is where you list medications, the reason for the medication, which physician prescribed them, what side effects they have, and your 6-month review. Page 3 has information about personal care, including things like grooming, diets, bathing, toileting, and other self-care issues. Page 4 addresses behavioral patterns, things like wandering or abusive or harmful behaviors, any suicidal or destructive tendencies, and what capabilities the individual has in an evacuation. Page 5 addresses physical health. What's the individual's general health now, their current status, what kind of services are being provided, what the goals are for that service, who is going to provide them, and a 6-month review, 6 and 12-month review, and then signatures of the individuals that are doing the reviews. You see that there's a process involved here. You don't just identify the issue, you identify the specific issue, then you make a goal, you decide who's going to meet the goal, and then you review and update the information. And you can imagine after a year or so, this form becomes messy, and that's okay. It's supposed to be a working document. When it gets to the point where it's difficult to read, make a new sheet, and then just make a notation, refer to next page. Don't try to cram a lot of information on here. Be sure you write in pen, and be sure you don't scratch out information. If you need to make a correction or if you make a change, draw a single line through, date it, initial it, and then tell what you did, what kind of change was made. On page 6, you'll see that we have goals and outcomes for mental and emotional health. Page 7 is about social participation, and it's very specific. It talks about how frequently you're going to provide services and who's going to provide them, and any changes and signatures. Page 7 addresses social participation. It talks about interpersonal relationships, what their current status is, what the goals are, who's going to help you meet those goals, how frequently it's going to be addressed. You can see that, again, it's a process. It's not just a one-time thing. Page 8 talks about independent living skills. And if you recall, our goal in a CBRF is always to encourage independent living skills. So we want to help people with their communication skills, with their food preparation. We want to help them get out into the community and be part of society in general. So that sort of wraps up the ISP. I think that a lot of people have bad feelings about doing this because it's actually a form, but this can be one of the most useful tools in your facility for caring for your residents because it has so much information there for you. Let's talk now about the annual review. What is an annual review? It has three main parts. First of all, it's a written summary of the residents' satisfaction about the CBRF services. Secondly, it's a written update of the assessment and a written update of the ISP. So we've covered all of that information except the resident satisfaction survey in the video up to this point. Why do we do an annual evaluation? Actually, we may do an evaluation more frequently than annually, but it gives the resident, first of all, an opportunity to express his or her satisfaction. And there is a specific form that's used, that's mandated for that satisfaction survey. If you look at the survey, it provides you with a benchmark by which to measure your own services. It tells you how the resident and the resident's family are going to judge you and your services. It lets you then decide whether your performance is what you want it to be or whether there are areas that you want to improve on. There's always room for improvement for all of us, and when a resident is asked to formally provide that information, usually they'll be careful and thoughtful in the provision of it. The annual assessment is to help you update what the residents' interests and needs are. And all human beings change, so in the period of a year, you can certainly expect that your residents' interests or needs may change. Again, the annual evaluation is going to be completed by the resident and or the resident's guardian or agent and the CBRF staff member. You need, again, to get input from all of the healthcare providers so that you have up-to-date information. You need, in the annual assessment and the update of the ISP, to include all of the pertinent providers of care. And preferably, you want to bring those people together for a discussion about where this resident is going as far as their life, the goals and objectives of their care and their everyday living. What does HFS 83 say about the annual evaluation? First of all, it says that you must use this particular form, the DSL 2372 form. Okay? That's a required form. And it has to be completed within 30 days of the date that it's due. It has to be included in the resident's record, and it must include the ability of the CBRF to provide the services that are needed, what the qualifications and the number of staff are in the CBRF. It reflects what degree of dignity and respect the CBRF has for its residents, and whether they are providing food, shelter, and clothing in a more than adequate way. Are they managing the funds and the activities of the resident in an acceptable way, in a way not just acceptable to the state or to the CBRF, but also to the resident and the resident's family. And our changes that are being made by the CBRF, say in provision of services or fees, are those being given to the resident in a timely fashion? So Once it's completed, again, these forms need to be signed by all the involved parties. They need to be signed by a representative of the CBRF and by the resident or the resident's agent, and then put into the resident's record. Right now, I'd like to go over the resident satisfaction evaluation and the kind of information that's been included here. This is a draft, so the actual form may change by the time it gets to you, but it does give you an idea of what kind of information the resident is going to be asked about your CBRF. First of all, it lists the kind of activities and services that all CBRFs must provide, and it asks your resident which ones they use. And then it offers a space for them to include other services that are not listed, that weren't required, but that are also offered to that resident. And what kinds of services that are not offered that the resident would like to have offered. Then it asks for general satisfaction. Are you satisfied overall with the facility? Are you satisfied overall with the care you're receiving? Does it allow the resident to make his or her own decisions about treatments, use their own physicians or pharmacists or therapists? Do they meet the individual's preferences for service providers and services? And does it offer a variety of activities to choose from? They want to know specifically what kind of activities residents participate in and the degree to which they participate in them. They want to know whether the resident believes there's adequate staffing. Whether you believe the staffing is adequate or not is not as important here as what the resident perceives. And they also want to know if the resident perceives the staff members as being competent and responsible and respectful. They want to know if the resident has had his or her rights explained to him or her, and whether or not the resident believes those rights are protected. And interestingly, there's a very long section on the food. So if you're not a very good cook, or your cook is just not extraordinarily good, you might want to go through this form, because people view food as a very important part of their life. And so the section on food talks about quality, nutrition, how well it's prepared and tastes, if the temperature is correct. So you want to be sure you're serving good food to folks. They want to know if the resident sees his or her room as being comfortable and in good repair, whether it's neat and clean, if they're comfortable and feel safe, and if their privacy has been respected. And if you recall, the resident has a right to privacy, so you want to be sure at all turns when you're providing services or cares that the resident has been informed that those can be provided in privacy, all of those services. It also asks how the facility is doing handling the residents' money, and whether they are receiving written notices about changes in services. It talks about who controls medications and how the resident believes that's going, if they're receiving them in an acceptable manner, in a timely fashion, and as prescribed. And then it asks, what changes or improvements could the facility make? This is a document that will provide you with constructive criticism of your facility. And so it's not something you need to be defensive about. It's something that will allow you to improve your services and will let you know where you're doing an extremely good job now. In the next section, I just want to touch on the issue of respite and terminally ill residents. Not all facilities will be equipped or even asked to care for individuals who meet these criteria. But should you decide to consider a resident who is a respite resident or who is terminally ill, you need to review the portions of the law that are applicable, because there are very specific requirements for the ISP and for who needs to be included in the care, who needs to be notified, and how soon and how frequently those plans of care need to be updated. So if you do decide to help those particular kinds of residents, be sure that you look up the rules before you approach it. Now, we're going to talk next about interviewing skills and techniques. Interviewing is both an art and a science. And the purpose for interviewing is to share information and to clarify and collect information so that you can accurately understand both the resident and the resident can understand you and your facility and the services you provide. It also allows you to create a caring and supportive relationship between the resident, the prospective resident, and his or her family member, and you as the caregiver. And it determines the appropriateness of the CBRF resident to your facility. Your attitudes as an interviewer are really critical. You need to, again, to ask questions that can easily be answered honestly. And to do that, you need to be very open. You need to be obviously not judgmental. Try to be friendly without being too informal. You want to be supportive. Usually when you're interviewing a prospective resident, the individual may be anxious or embarrassed or nervous or tense because it is a position where they're really put on the spot of having to make a decision about a major life change. So you want to be as understanding and caring as you can. You want to be sure that you give sufficient attention to detail without getting hung up in a lot of details that aren't helpful. You want to try to be patient, and particularly with older residents and people who have sensory impairment or who have some dementia, you want to take your time. Don't rush people. And then also treat the person with the dignity and respect that you would hope for yourself. Before you go into an interview, always familiarize yourself with all the data you have about a resident. You want to organize that information, list questions that you're going to be needing to ask or clarify, or information that you need interpreted because you're not sure about it, that information that comes from the resident's records. So organize all of that information. First of all, it will make you feel more confident and comfortable. And secondly, being organized is something that matters to a resident. They don't want to just come into a facility that somebody's saying, oh gosh, I've got that paper here someplace. It just doesn't give you a feeling of confidence about a facility if they aren't organized. So familiarize yourself both with the information and with the format that you're going to be putting that information into. And then make sure that you have some coverage for the other activities in your facility. You want your interview to be conducted without a lot of interruptions. You want it to be conducted in a quiet, private area that has adequate lighting. And you want to make sure that both the interviewer, you, and your prospective resident and family member have things to write with and things to write on so that you can all take notes so it doesn't look like one of you is being imposing. It's a give and take operation. First, you want to begin your interview by introducing yourself and welcoming them to your CBRF. Secondly, you want to explain why the interview is necessary. Hopefully, you will send out a copy of the interview sheet to the individual before they come for the assessment. That'll give them some confidence about what's going to happen. Otherwise, they're just coming in blind and they have no idea how long it could take, what kind of information is going to be covered, and in what depth. You want to know. You want to be able to tell them what content is going to be covered and about how long the interview will take. And then you want to show that you're flexible. You want to say, this may get long, so If at any time you want to take a break, or if you need a glass of water or soda or something, we can do that. There's not a problem. And then I would like to take you on a tour of the facility. Be sure that they understand that the content of the interview is confidential. Let me just go over some of the general guidelines for interviewing. First of all, you should all be seated comfortably and at the same eye level. Try not to have any phone calls coming in during the interview. And keep in mind that while you may be a little anxious to get all of your paperwork done correctly, these folks are considering a major life change, so they may be pretty nervous. And you want to try to comfort them and make them feel comfortable. Also, that family members may be having a lot of guilt or concern about having their prospective resident come to live with you rather than living with one of them. Use all of your senses. Use the ABCs, the appearance, behavior, and communication patterns of both the prospective resident and the family members to gather information from the interview. So you're not just taking notes about the spoken content. You need to get a feel for how this person behaves, how they communicate, how they smell, what kind of body language they use. You're going to be looking at their appearance, their general hygiene, what kind of gestures they normally use. Do they have tremors or a Parkinsonian type motion? Is their behavior consistent with the kinds of questions or the setting in which it's being enacted? Does the person act bored or indifferent? What kind of communication style does the person use? Are they focused? Are they able to connect words into phrases or sentences? Given a chance, can they express themselves well? And what kind of concerns do they appear to be focused on? Be sure that you focus more on your resident rather than on yourself. You're there to complete your form, certainly, but you're mostly there to gather and clarify information. So you want to make eye contact frequently, and you want to use simple language. The point is to communicate. You want expression, not impression. Just because you know a lot of big words doesn't mean that you have to use them all. So you want to use words that you know the resident will understand and not be intimidated by. You want to encourage that person to feel comfortable expressing themselves to you. Be sure that you allow adequate time for a resident to process questions and then to respond. And this is very difficult, especially if you're not accustomed to working with older people. As I said in the medication units, slower processing is a normal change of aging. And so you need to allow for that to occur. If the resident doesn't appear to understand a question, you might want to rephrase it and be sure that the individual can see your face, your intonation, and your lips, because it may be that there's a difficulty with some sensory issues, for example, hearing. Be sensitive to the questions that may be embarrassing, and try to start your interview with something a little more neutral and establish a rapport or a relationship before getting to things like bowel movements or urinary incontinence. Try to use open-ended questions. This is something when I do a workshop, we practice on this, because open-ended questions are where you ask someone questions that begin with words like who, why, where, when, how much, how often. We try not to do too much of the why questioning in the assessment, but we want to know how the resident lives, okay? And by asking how or what, we're more likely to have the resident tell us more useful information than if we ask simple questions that can be answered yes or no. So this is something we practice, and you might want to practice this in your facility. Keep track of how many times you actually offer a leading question, a question that says well, you like this, don't you? That tells the person being asked what kind of answer you want. And that's not your goal in the assessment. Your goal in the assessment is to find out really what the prospective resident has an interest in. You may want sometimes to use questions that are yes or no to begin or end a segment of an interview. Avoid using why questions, because a lot of times, particularly if an individual has not thought about matters very carefully, or if they're under a lot of stress, or if they have a dementing illness, they may not know why they do certain things. And it may be intimidating or disconcerting to the person to be asked why they do it. You can use broad statements like, well, how would you approach this? Or what more would you like to tell me about that particular issue? You want to keep the conversation going, and you want to keep it focused. So you want to be using body language and phrases that go, you know, that indicate that you understand and that you're listening to what the individual is saying. So you want to actively listen. You want to attend to what that person is saying. Be sure that the resident, the prospective resident, has a chance to say what he or she needs and wants to say. Okay? That may take longer than you expect. Observe them for possible fatigue or short memory, and then break it up a little bit. Take a break. Suggest that you take a tour of your facility, get a beverage, take a stretch break, or just say, boy, this does get a little long, doesn't it? And just lighten things up a little bit so that the resident doesn't get too fatigued. The person may have conditions that make it very difficult to concentrate. And so don't expect them to be, you know, the Rock of Gibraltar during this whole interview. Gently learn to end a conversation that's starting to be repetitious, and a politely worded, closed-ended sentences that can be answered with a simple yes or no is one way to do that. So you can say, well, was that all that we needed to cover on that topic? When it appears that the same information has been repeated several times, that might be one way to close that topic and move on to another one. There are some things that can make interviewing very difficult. First of all, if you as the interviewer are doing all the talking, you're not learning about your prospective resident. So you want to pose open-ended questions, and you want to be sure, though, to answer questions that are posed to you. But answer those briefly. Okay? Try to be as concise as you can. Avoid putting words into the mouths of the people you're interviewing. And clarify rather than jumping to some kind of a conclusion. Don't try to placate a person by saying, oh, don't worry, it'll be okay. Okay? And allow adequate time for your interview. If you get interrupted, what you're going to find is you have to reestablish the mood of the interview, and that will take a lot of extra time for every interruption. So try to plan it so that you don't have those interruptions. Be aware of your own prejudices and your own insensitivities. We all have these blind spots. You need to try to be aware of that. And an example of this is what I always termed the cute factor, and that was that people who were attractively groomed, always seemed to be more competent than people who were not attractive and attractively groomed, and people who were dirty or poorly groomed or smelled of urine. So you need to be aware if you have a prejudice like that, and take that into account and try to overcome it in your interview. You need to remember that people's cultures are different, and if you are interviewing someone from a culture that's very withdrawn, or that a culture where making eye contact is not appropriate, that you don't misread that as being insensitivity or indifference. language barriers can make you think an individual, language and sensory barriers can make you think somebody is more mentally confused than they are. Now, an individual may be confused because of dementia or because of infections or other acute illnesses. So you need to try to get a feel for what's going on with the person that particular day, as well as in the general sense of their life. If the person can't understand you or can't hear you, obviously your interview is not going to go well. And when you have a situation where the verbal and nonverbal messages a person is giving you are different, almost always the nonverbal message will be more correct, and you need to try to clarify why the person is telling you one thing and their body is telling you something else. Another problem is when one of the people you're interviewing is saying yes and the other one's going, oh no, that's not true. So you're going to have problems with an interview in that situation. Another thing is what I'm sure you found from these videotapes, and that is overload of information. With a videotape, you can be blazing along and say, I've had enough, and you can stop it. When you have someone in an interview situation, they're trapped there. And you need to be cognizant of the fact, you need to be aware of the fact that you may just overload them completely. So try not to do that. Try to stay brief, straightforward, and keep it on track. And then offer to write down answers or to set up a second appointment if that would be appropriate. Make sure that you take into account bodily needs that could be interfering with attention. If a person needs to use a bathroom, or if they're thirsty or tired or they hurt or they just need to move around, those things are going to interfere with the quality of your interview, and you need to be sensitive to those things. So I guess what I would suggest is practice your interviewing techniques and practice them on each other with your coworkers. And I think you'll find that when you actually ask open-ended questions, you'll find out a lot about the people you work with that you didn't know before because you've been making some assumptions about them that they are very much like you are, when they may be very much different. What we're going to do now is we're going to show you what an assessment interview might look like. And again, I want to thank Jan and Phyllis for taking the time to help us with this interview. Hi, I've been preparing for my interview with Jan and her daughter. Now, Jan is my prospective client, and I have requested a lot of information about her from her primary caregivers, from the hospital that recently discharged her. And I sent out a copy of my assessment both to my prospective client and to the daughter that she's been living with since she was discharged from the hospital with a hip fracture. What I've done is I've filled out as much of my assessment form as possible, and I've highlighted some areas that I need to clarify or that I have conflicting information on, or that just I find particularly useful in deciding if someone is appropriate for my CBRF. Now, when someone comes into the facility, normally they're a little bit nervous. Moving is stressful for everybody, and especially when you're thinking of giving up your home and some of your independence. It can be very stressful. So what I want to do is I want to know as much of the controversial and personal information as I can before she arrives. And then I want to be sure to start someplace that's not quite so stressful for her. So I'll probably end up starting on page 4, which is talking about her sensory status. That's something most people don't mind talking about, their eyeglasses, for example. Let me tell you a little bit about Jan before we get started. Jan had osteoarthritis, and she was diagnosed with congestive heart failure. As a result of what we think could be mild dementia and her other conditions, which include depression, she had a fall and sustained a hip injury. Actually, she had a fracture and was hospitalized. After the fracture, she was released to her daughter's home. Now her daughter works full-time, and it has not been going very well for the two of them. It's been very stressful. And because her mother has been living alone for so long, she just is not very pleased with the setup either. So the two of them are a little bit at odds. I have a listing of Jan's current medications, and they include some Relafin, which she takes twice a day for her osteoarthritis. She's taking a water pill for her heart condition. She's taking furosemide. She takes Zoloft for her depression, and she's taking a multiple vitamin. And as far as I know, she has a penicillin allergy. Now, some information like that we're going to clarify, not just because we want to know, is the information correct, but we also want to know, what does Jan know? Who's been handling the medications? Has anything changed since the information came to my office? So, what I would do then is, I've made a photocopy of my original form. This is a sneaky trick that I use, because when someone comes in to interview, I want to concentrate on them, not on making sure I'm writing in the lines, okay? Then I can just scribble all over this paper, and I can go back to my original nice copy, and I can fill in the blanks. So I've done that, and I'm ready for my clients to come in. I think we're ready to begin now. Let me introduce myself. That was one of the interviewing techniques we talked about. Ladies, welcome to my CBRF. I'm Maren Meyer. I'm the pharmacist, but I do the initial assessments. You must be Jan. Is it okay for me to call you Jan?
Yes.
Okay, or would you prefer to be called Mrs. Lathrop?
Jan is just fine.
Okay, and you must be Diane.
Hi, I'm Phyllis.
Phyllis?
Yes.
Oh.
I'm Jan's younger daughter.
I see. Oh, and now, where are you from?
I'm from Arizona.
Oh, so you've come up to visit and, okay.
I want to spend some time with Mom and do some things together, and so it's a good time of the year for me to come, and I'm looking forward to it.
Okay. Now, Jan has been staying with Diane. How often do you see Jan?
Well, it's been a while.
A long time.
It's been about a little over a year, Mom, right?
Oh, seems longer.
Well, I keep in touch by phone, and I talk to my sister, and so I'm in touch.
Okay.
And she's looking good, isn't she? I mean,
She
you
looks
don't know her, but
terrific.
yes, for her age, yes.
Okay. I have, as you know, I have a lot of questions that I'd like to ask you. And some of them are very personal, some are not so personal. But what we want to do is get an idea of whether we would meet your needs if you were to move in with us here at the CBRF. So I'll ask you questions about all sorts of things. For example, your glasses. I see you wear glasses. I have glasses too. I wear them mostly for reading. How are your glasses working for you?
Just fine. I can't go anywhere without them, and seems as if I'm always hunting for them, but I need them.
Okay. Have you ever had any eye surgeries?
No, never.
No cataracts, for example?
No, never.
No cataract surgeries. Okay. And do you use any kind of special equipment? For example, a magnifying glass to read the paper with, or?
No, it's just, I wish I had these tied to my neck because I can't find them.
But we all have that. I mean, I wear glasses and I lose them all the time, so that's just, you know, has nothing to do, we all do, don't we?
Well, it can be difficult keeping your glasses with you. How's your hearing?
Well, my daughter says I can't hear, only when I want to, but it's fine. I can hear.
Right. Like anyone, when you get a little older, you know, the hearing is probably a little bit more of a problem. I have to sometimes mention things 2 or 3 times when I call, but you know, sometimes your mind is thinking about other things. Just the same thing when she calls me. Sometimes you're just not listening properly, but I think hearing is okay. Right, Mom?
I think so.
Okay. Now, do you have a hearing aid? I had information from your doctor that you had a hearing aid.
Oh, maybe that's the problem. I put that thing away.
No, you have to start wearing it again.
I didn't think I needed it. It's in my drawer.
Well, maybe the hearing aid is something that we could help you with. For example, we could make an appointment with an audiologist and see if you really need that hearing aid. A lot of times people need a hearing aid or they need a different hearing aid than they have. Maybe you've had trouble with the batteries and so it wasn't working well for you. So that's something that I'll make a note of, and if you do come to live with us, it's something that we can work with.
And perhaps you'll find out she doesn't need a hearing aid.
That's right. That would be nice, but if she does, then she'll have it and she'll be able to watch TV or listen to the radio.
That sounds good.
In this interview, I'm going to be jumping around. I've looked over all these questions in advance, and I know some of them I'm not going to be able to ask directly. For example, on page 5, I'm certainly not going to say to Jan, "Are you lethargic and fearful, or depressed, forgetful, and confused?" Some of these questions are things that I'm going to answer after the interview, or I may pick up on as we go along. So that would be maybe just a note. If I notice that she was particularly anxious, I may make a note at the bottom of any page and go back and collect that information after the interview. What I am going to do now is I'm going to move on to the self-concept, which is also on page 5, and find out a little bit about how she gets along with other people. So let's see how that goes. Well, Jan, when you were living alone, you were in an apartment.
Yes.
And did you interact with a lot of other people there?
Oh, there's such some busybodies there. And I
Oh, you
like
did a
to
lot
spend,
with them. Those busybodies. You love those busybodies.
I like some time by myself. I just can't imagine living someplace where you don't have some time
But
to yourself.
Mom, you always played bridge with them. Remember, you had your investment group. You liked that kind of stuff. You're still doing that stuff.
Well, it seems like such an effort. And I'd like to have some time by myself. I can't imagine living someplace where you don't have some time by yourself.
Right. Do you have, I suppose you enjoy just staying in your room all day.
I could be happy. I like to read.
You like to be with people, Mom. I mean, you love it when the family comes over. You like it when Ethel and Marion come about. You go out for coffee. That's all a good time for you. And then you've got your certain programs that you like, but you like to watch it with your friends.
They don't like the same things I do. I just need some time. I really enjoy time by myself. Once in a while, I like to eat with someone else. I like the family to come and talk about the kids. But I like some time by myself.
I think you can see this is not going very well. There are a couple of things that could have been done here to avoid what looks like a possible confrontation between Jan and her daughter. First of all, I was expecting Diane, so Diane had the information, and I had spoken with Diane about the purpose of my interview. Phyllis is not privy to that information at this point. Normally I talk in advance with both the prospective client or resident and their caregiver and talk to them about the purpose of the interview. One of the purposes is for me to hear what the resident has to say about themselves. I then can allow the caregiver or the relatives to give me information at another time But particularly in this situation where Phyllis doesn't live with her mother and hasn't seen her on a regular basis for probably quite a number of years, Phyllis is probably denying a little bit the loss or the change of personality that her mother has had over the last several years. So what I might be able to do would have been to, as soon as I realized that I had the wrong daughter, or a daughter different than the one I expected, I probably should have prefaced my entire interview by explaining to her what the interview was about and what the purpose of the questions was. At this point, what I could do is this. Well, ladies, it looks like you have a disagreement on what kinds of things Jan really enjoys. I guess what we need to do is give you each a little time to express your opinions of it. And so what I'd like to do is I'll get Jan's ideas first, and we will all respect you while you're talking, and we'll give you an opportunity to talk uninterrupted. And then we'll pose the same question to Phyllis, and we'll all allow Phyllis to answer. How does that sound?
Well, it sounds okay.
Okay. The other thing that you may have noticed was that I was asking some leading questions. Questions like, oh, I guess you like being alone all day. That's the kind of question that's very difficult to answer honestly. It tells Jan that I want her to answer a certain way. If you recall from our segment on interviewing technique, it's important for me to be non-judgmental and for me also not to lead her to a particular answer that I might want her to give. And the best way to do that is by using the who, what, where, why, when, and how questions. I want to ask her how she spends her day. I don't want to tell her how I want her to spend it. Now, at some point in this interview, I want to tell Jan and Phyllis about my facility, and I also want to ask them about any concerns that they might have. Maybe at this point it would be good for me to let Jan talk about some things that she's very comfortable about, and those would be her social history. So, skipping around again here in the assessment, I'm going to go over to page 10. Jan, tell me about yourself. Were you a homemaker? What did you do with your time through your life?
I always worked. I took care of the children, my husband, but I always worked also.
What did you do?
Well, I was a teacher, and I enjoyed it very much. It was very important to me.
What grades did you teach?
I taught the high school students. I taught science.
A very good teacher she was.
How wonderful.
Yes, good mom, always there baking for us, and still does that. I think when I am home now, I'm hoping she's going to do some baking for me. And
now this is really important information for me to know, because if she, for example, had never been a teacher, I wouldn't expect her to have the same level of literacy as someone who stayed home and maybe didn't do a lot of reading or hadn't done a lot of studying. So in Jan's case, if I find that she's having a hard time understanding the weather or doing her simple checkbook calculations, then I would have a better idea that she did have some cognitive problems or a mild dementia. So this tells me a lot more than just what she's done with her life. So how many years did you work as a teacher?
I worked 20 years, and then I retired.
And what have you been doing since then?
Well, I do things around my apartment. I like to go to the library.
she's a hustler. She cleans that house, cleans the apartment just like she did the house, and she's just always been a bustling lady.
It doesn't seem so important to me anymore, though. The apartment is just, it gets dusty and I have to do it all over again.
Well, all our apartments get dusty, and that's okay because you have other things to do with your life now. You've got your bridge and things like that with your friends. So, you know, that's okay. I mean, you don't have the kids around anymore where you have to hustle and keep everything as spotless.
Now, do you enjoy the bridge as much now as you did before?
No, they're just a bunch of busybodies.
No, Mom.
I don't enjoy that anymore.
Do you do any kind of crafts?
Crafts, no.
No crafts? No
She's
needle
never
pointing?
been a big craft person. She's always been pretty busy with other things to do crafts, right?
Right.
Right.
How about television? Do you enjoy watching television?
I do. I do like television. I like the news magazines. I like those shows. But everybody else around me likes those soaps. It's aggravating. I don't like that kind of stuff.
Well, life changes, you know. I used to watch the soaps. I don't watch the soaps anymore either, but you've got all the other TV programs. You like the news shows, that's very good. It's the teacher in her, you know. She enjoys what's happening in the world and keeping up to date, and always has been that way. Taught us a lot. It's a good mom.
Nobody else likes the same thing, though. I worry about that if I move someplace else. Will I be able to have my own TV?
Now, here's a point at which I've let the conversation get away from me. This has become a conversation between the two of them instead of an interview. Jan is going to be somebody who may tire in the process of this interview. This can be, the initial assessment can be a very long interview, and it's very important to stay focused. So rather than let this become a conversation, I need to keep actively participating in it. I need to be encouraging them to talk, but keeping them on the topics that are most important for us to determine whether or not Jan would be comfortable here. And it sounds like having her own television is an important item. I could say, boy, it sounds like you would appreciate having a television in your room, and move on to another topic. So let's do that. Well, Jan, do you have your own television now?
Yes, I do.
Well, there would be no reason you couldn't bring that with you and have it in your room to watch by yourself if you wanted to do that sometimes. How would that be?
That would be best.
Okay.
Very important.
Let's talk now about some other things. For example, we need to talk about grooming. Do you do your own hair? Do you wash your own hair and set it?
Well, it's getting harder for me. I have to keep my balance in the shower, or if I want to do it in the sink, it's hard for me to put my head
That's why
down.
Diane is here. You know, that's the kind of things that daughters
she's
are to
busy.
do.
She's busy.
Well, we do have someone who comes in and can help you with your
Well,
hair
Diane's
washing.
always there for you, isn't she, when you need it done? I mean, or you could go to the beauty parlor. I mean, you always went to the beauty parlor before. You can continue to do that.
Well, and sometimes people's needs change. Because of her heart condition, it may be difficult for her, you know, to hold her hands up over her head. And it may be just time in her life when we need to see if there isn't another alternative, because Diane has expressed a problem with being available so much.
Well, then
It
maybe
just wears me out.
Okay. Do you also get worn out when you are dressing, or is that a problem for you?
It just seems like everything is a big deal now. It does wear
well, then
me
you
out.
just take your time. You know, you don't have to get dressed in 30 minutes because you got to be at your teaching job. You just simply take your time.
If you had some assistance, would that be helpful to you?
I wonder, it just seems so difficult having someone else help you dress.
Right.
I don't see that.
Is this something that's new, or is it since your hip fracture that it's become a bigger problem?
Well, yes, that's true. My hip all of that movement. I had to be careful what I chose to wear. But I was having some trouble beforehand too, just getting tired.
Any of us, you know, at times have problems like that. I mean, sometimes my arthritis kicks in and I have to do something a little bit slower, you know, or buttoning that last button,
It's
or
not like that. It's I'm
Let's-
old.
oh, you are not, Mom. You're as old as you make yourself be.
I think that it sounds like Jan could use some of the services that we provide. And
She's got 2 daughters. You know, I mean, I know I'm a distance, but you know, Diane is closer, and that's just the way it works. Now, you know, Mom could come and live with me for a while. She doesn't want to do that, but that's her choice. But Diane is here, and that's what daughters are for. You
It
know,
just doesn't seem right. She's got her life.
got to keep an up attitude, Mom.
I think this would be a good time to take a break in this interview. Things are just not going well. And it is a long interview. So what I would probably do now is make a transition and say, why don't we take a look at the facility? And you can use the bathroom if you need to, and we'll get some beverages and move around a little bit because we all get stiff sitting around. And then we'll come back, and that'll let the air clear a little bit between these two. And it'll also give me an opportunity to talk to Phyllis so that she realizes that she doesn't need to defend her position here, that she's not on trial for not being a perfect daughter. Now, we've taken a tour of the facility. We're all settled in. We've had something cool to drink, and we're back at our interview. We've kind of covered a lot of the other information now. And now it's important that I give them both an opportunity to talk about how they feel about the situation. So let's approach that aspect. Well, you've both been very helpful, and I appreciate that. And it does look to me like you would be quite an appropriate person to have live here with us at the CBRF. How do you feel about that, though?
Well, it's very upsetting in a way. It's going to be such a change. I like the surroundings. It would be nice to not have to worry about some things. I'm worried about, will I make a friend? Everybody around here looks, I don't know if I could be friends with anybody.
Mom, you got a lot of friends at home, a lot of people all around you at home.
Well, and I think what you would find is you could do this on a trial basis. Okay.
Oh, I can?
Yes. We aren't going to make you a prisoner here. This is just another way to live rather than living in your apartment. And you could have your privacy when you wanted it, but we would want you to come out and participate in some of the group events. And the reason for that is that it's human beings are social animals, and that's a good way to get to know people and to decide whether they would be people that you'd want to be friends with.
Thing is, you know, then if you do something like that and your apartment's gone, then you find out you don't like it there, you want to be back home, then, you know, the place is gone, and, you know, Diane will be busier, that might not be available. I mean, all that's got to be considered. And the cost, if she's just trying it out, do we pay full cost? Not that the money is that important, Mom, but, you know, it's got to be the right thing for you. And, you know, like I said, we all get our down days. I mean,
It's such a big decision. If I don't want to play bingo, do I have to? I mean,
Absolutely not. But like I said, in order for you to make some friends, we would want you to come out of your room once in a while. We'd want to see that smile that you have there.
well, I wouldn't want to be a mole in a hole, that's for sure. But there are some things that are just
That you
downright-
don't enjoy. And that's perfectly okay. The other thing is that when I talked with Diane was feeling kind of guilty about thinking that she couldn't provide good care for you. And she wants you to be nearby because they've gotten used to being in the same town together. And I think that may enter into part of the problem
Well, you know,
with
there's
her
nothing-
coming away to Arizona. While she expressed an interest in staying here, it certainly didn't sound like it was something that meant that she didn't want to see you too. And she can have visitors privately in her room.
I hate the heat out there. You know, I hate the heat.
Well, I know, Mom, but you know, it's a big change. You know, we are your daughters. You know, you took care of us when we were growing up. You know, I think we should be here for you, you know, if you do need some assistance.
Right.
And
maybe this is one of the ways that you can let her stay as independent as she can safely be without being in your home. Because it sounds like from the other things that you've told me that you have a very busy lifestyle and that you do a lot of traveling, and that having Jan come and stay with you would really interrupt your lifestyle. And she didn't really want to do that.
Be just like with Diane. She's busy. I was busy. It wouldn't be the answer.
I don't know, Mom.
Well, I want you both to feel comfortable talking with me about it and going home and talking with each other and with Diane. But ultimately, what we want is we want Jan to find a place where she's around people during the day so that she's safe and has some assistance with her medication, since we agreed that she's kind of having some troubles with that. And she gets a little help with toileting, which has been a problem because of her urinary tract infections. This is a group home. It's not a institution. It's a home, and it's as home-like as it can safely be for everyone.
That's my biggest fear, is that wouldn't be an institution, that she could be her own person, and
Right.
and her family would be there. She could take those telephone calls. There's not always a nurse telling her when to eat, when to sleep, when to, you know, I mean.
I couldn't stand that.
Right. See, that's important.
The intent of a CBRF is to have as home-like an environment as possible, but to offer some of the assistance that she needs in everyday activities. For example, we can help her with the laundry. Now, she's perfectly able and enjoys folding and ironing, so she'll be doing her own folding and ironing. We're not silly. We're not going to take over doing a task that she already enjoys and does well. Now, this is a very long and taxing part of an interview and an assessment. And what we've done is we have discussed all the pros and cons until we kind of have a feeling that everyone's vented both their frustrations and their fears. Let's go back to our interview now. Well, how do you feel about giving it a try, Jan?
Well, if I don't have to, if this isn't set in stone, I could try it. I'd really like not to be a burden to Diane, and moving to Arizona, I'd just be a burden to you. I like still being in charge of my life, but and with a little help. Sounds like I could be fairly independent here. It looks home-like. I wouldn't have that big apartment. My laundry is all on one floor. That would help.
First of all, Mom, you would never be a burden to us. You are our mom. But I do respect what you're saying. And I think Diane and I and you need to talk. And if Mom thinks this is the way to go, then we just have to readjust, and we'll talk.
We'll try to help you do that. Thanks a lot for coming in. I know it's been a long day, and we can get back together again. Feel free to give us a ring on the phone anytime. And why don't I talk to you on Thursday? How does that sound? Would that give you enough time?
I think that's good.
All right, will you still be here on Thursday?
I'll be here.
forget.
You
I'm
betcha.
going home.
I'll be here. We'll talk and get Diane, and three of us will talk.
Okay, terrific. Thanks a lot.
Thank you.
What ABCs did you see in Jan during the interview? If you recall from the interviewing segment, A, B, and C stand for appearance, behavior, and communication. Jan's appearance was a little disheveled for someone who had been a teacher and had obviously gotten up and gotten dressed and probably had her hair all done. Her hair was a little disheveled. Now, that could just be because she's been ill, but that does tell us something about her ability to groom right now. Her skin looked a little dry, and there was a hint of urine about her. She also didn't use a lot of body language. While she used facial expressions, she didn't move her arms very much, and she didn't use hand gestures, although her daughter did. And usually a family will have similar patterns of body expressions, although not always. Her behavior, really she did very well with the questions, but her daughter Phyllis kept interrupting her, and that interruption of her train of thought made some of her answers a little fuzzy. And she was mostly reacting to what Phyllis was saying and not so much to the questions. And that's really the shortcoming of the interviewer, not the interviewee. She wasn't sleepy, and she really wasn't bored, although when we talked about her incontinence, it did hurt her feelings, and we had to regroup then and go back over information. Her communication seemed totally appropriate. I think that if she had been given more of an opportunity by Phyllis, she would have expressed her own feelings a lot more freely. And maybe it would have been a good idea to have asked Phyllis if we could just talk to Jan about her feelings about coming to the CBRF alone. There are a couple of techniques that you may or may not have noticed that I used in my interview. First of all, I like to ask the individual if it's okay for me to proceed and ask the questions. I know that they'll say yes, but it's just something that's polite. After that, I try to use open-ended questions and ask the individual to tell me how or where or how much or when they do certain things. And when I want to end a segment of the interview, I use a yes or no question. That's something that kind of wraps things up. Was there anything more that you wanted to say, for example? That can be answered yes or no, or it could be answered with more information. So those are just some techniques that you may want to become aware of. And as you practice them, I think that you'll find you'll become more comfortable and you'll find them more useful in keeping your interviews on track. So you can see how it is really an art form to gather all of this information. And certainly it's written all over my paperwork here. What I'm going to do now is I had arranged coverage in the CBRF so I wasn't interrupted, so that I didn't have telephone calls, I didn't have med passes to do. Now I need to check and make sure that everything's going well in my facility. Then I need to sit down and immediately make my notes so that I remember the tone of the conversation, that I remember the name of Phyllis's husband and her children, so that I have the important bits of information gathered here where they are retrievable. I hope that this interview has helped you get an idea of some of the difficulties that I run into and given you some ideas on how to resolve the issues that you no doubt run into when you do assessments also. I'm sure you've had some experiences like that interview yourself, and if you haven't, you certainly will. The next part of your workbook covers the code, the related parts of HFS 83 that address assessment, ISP, the respite and hospice issues, and the annual evaluation. Be sure to sit down with these and read them. And what I would suggest is that once a month you sit down and read some of these rules. because the more you read them, the more familiar they'll become, and the easier it will be for you to incorporate them into your daily routine at your CBRF. Now we're going to wrap up this part of the unit by performing a post-test. It is the same test that you took as the pre-test, and there is no grading, but we will go over the answers after you've completed it. So now you can stop the video, complete the post-test, and then come back. Welcome back. I hope that wasn't too difficult. Let's go over the answers. Number 1, the resident's guardian, agent, or designated representative, if authorized in writing by the resident, may inspect, copy, and challenge the accuracy of the resident's records. That's a true statement. Number 2, the pre-admission assessment must be a face-to-face interview by the designated CBRF staff person with the prospective resident and his or her guardian or agent before the prospective resident is admitted to the CBRF. That's true, except in a situation where an admission is initiated by a court action. In that case, it has to be done within 5 days of admission. Number 3, a written authorization from the resident or the resident's guardian is not necessary to obtain a release of records from other service providers who are knowledgeable about prospective residents' interests, abilities, and needs. That's false. To make it correct, you need to know that a written authorization is always needed from the resident or the resident's guardian or agent before any records are released from a service provider. Number 4, the ISP is a written document developed from the pre-admission assessment and is to be completed within 30 days of the resident's admission. That's true. Number 5, the ISP is completed by the CBRF nurse. That is false. The ISP is to be completed by the CBRF staff person that's been designated to do so, not necessarily a nurse, and completed in cooperation with the resident, his or her guardian or agent, and any other service providers involved in the resident's care. Number 6, the ISP establishes goals to be accomplished through services provided for or arranged by the CBRF. That's true. Number 7, the annual evaluation includes a written summary of the resident's satisfaction with the CBRF's services and a written update of the assessment and the ISP. That's true. And you must use the mandated HFS 83 form for the resident survey. Number 8, the assessment, ISP, and annual evaluation must be agreed upon and signed by the resident and his or her guardian or agent and the designated CBRF staff person. That's true. Number 9, when interviewing, use your senses of sight, hearing, touch, and smell, the ABCs, when gathering information about a prospective resident. That's true. Number 10, when interviewing, it's best to ask questions to which the resident can answer yes or no. That's false. It's best to ask open-ended questions that allow for more interaction and clarification. This will conclude the assessment, ISP, and annual evaluation in the CBRF unit. Thank you for being with us.